Very good morning. Just now I realized that it was a debate. Neither Meenal nor me were prepared for debate. I think till yesterday night what we both did was sharing each other that ठीक है रात के 1 बज गए अपना slide deck नहीं बना है. But we did manage to somehow finish it at 2 o'clock and then both of us are here. So I think in this world of diabetes where we are talking so much about management, we are, I would say, becoming very, very narrowistic when we are treating our patients. Whenever we are talking about management of diabetes, we are talking so much about the CRMs, but believe me, if I have to ask you, for a diabetic patient, what will you want to do? First thing, so that if I give you a choice, if you have two patients, one arm, there is one patient where you want to aggressively control the sugars. Another arm, you want to give all the drugs which control the CRMs, pleiotropic benefits, your SGL2s, GLPs, everything. Still the sugars are not controlled. So what do you want to do? Sir, what do you want to do? You want to control the sugars first for diabetic patient, or you want to look up the heart, kidney? Sugar हुआ तो हुआ, नहीं हुआ तो it's okay.
Somebody with, sorry. If I get somebody with 180 or 200, I won't jump to drug, no. So I will give him, lifestyle changes. I will put him on some diet, call him again next week, and very judiciously go on adding drugs. This is what I would do.
Very, very true, sir. I think that speaks a lot about your experience as well. So we all know that diabetes is a progressive disease. When we diagnose somebody with diabetes, at that time 50% of the beta cells are already exhausted. So whatever you have to do it very, very aggressively. And we have seen now, after Defranzo's octet, we have seen almost, at least what we know till now, there are 8 different pathophysiological mechanisms leading to hyperglycemia. And the global burden and the burden of India, I think the burden of India is also very, very high. In a country like India, now my next question is, can anybody tell me, probably I think I have, my co-chairs or the chairpersons are saying, you're not asking us why are we sitting here. So okay, now you can take the question. How many fixed dose combinations are there in India? Make a guess.
No clue. I know 133 were banned.
She's been hardly been. Minal wants to say. Yeah.
There are so many and every.
That's the advantage of having a co-speaker with you.
No, but every day there are new coming out. Even like yesterday.
You don't look at the pharma guys there.
There are just too many and it just doesn't make sense after a point.
So you'll be surprised, India has more than 500 fixed dose combinations. That's a humongous number. We will tell so much that yes, these are rational, these are irrational. So I will come to one by one that do we require fixed dose combinations, and if yes, then what the guideline says and what you have to do. So whenever you're thinking about starting a drug with fixed dose combinations, I think a few things which you have to look at is drugs in combination should have different mechanisms of actions. So when we're talking about fixed dose combination, you cannot add gliclazide with glimepiride. You have to have 2 fixed dose combinations acting on different mechanism so that when given together they do the synergism. The pharmacokinetics of drugs must again be different. So you do not want to give drugs which interfere with each other. combination should not have additives that can induce the toxicity. So whenever you're talking about 2 drugs, probably 3 drugs, my colleague will speak. So you do not want an addition of AEs when you are giving these drugs. And then of course, we are living in an era of evidence-based medicine. So it has to be supported by the guidelines. I think we are far moved ahead from where I want to do what I have done to evidence-based medicine, that what evidence says. So coming to the merits, why are we using? I am sure all of us here have used or using fixed dose combination. Can I see anybody in this room who has never used a fixed dose combination? Nobody. तो हम इंडियन है ही नहीं. As Indians, we love fixed dose combinations. Why we love 3? So I always say there are 3 C's when you talk about fixed dose combinations. First, it improves your compliance. I will talk that in the slides. Next, it improves your control. It gives you a better control. And then third C is the cost. In a country like India, you just cannot leave that. Whatever we say here, when we are sitting in our OPDs, I think these 3 factors will always play in. So fixed dose combinations improves the pill burden, it reduces the pill burden, reduces the medication error. So certain times some medications are before, some are after, some are during, 1 hour before, 20 minutes, 30 minutes. I'm sure none of the patients are working with alarms to have all these medications. And then yes, it reduces the costs and as well the demerits. So there is always demerits of fixed dose combination as well. Whenever you want to intensify a drug, so if I am giving probably a glimepiride 2 milligrams with metformin 500, and then if I only want to intensify it to say 850 and 1000, now probably we have, Minal is giving me a stare look, you mean 850 and 1000 is not there? Yeah, she has come very well prepared. So then then intensification always be a problem. Risk of drug-drug interaction. So certain times, if you have say nephropathy patients, moderate to severe in nephropathy patients, where you can give certain drugs, say linagliptin with metformin. Your patient is going into moderate with severe renal insufficiency. You are comfortable with lina. You can give it for severe, but you can't give metformin. So you will have to either remove metformin or at least reduce the dose of metformin. What does the government regulation says for FDCs? We have one of my very good friends, Sandesh is here. He was with me in ISCR. Both of us, we were chair and co-chair. We were doing a lot of clinical trials. So he is a man who knows more, I'm sure, about the government regulations, because he is working very, very stringently on the guidelines. So you will see there are certain policies. Certain times we all feel na कि अरे ये company ने ऐसे कैसे ला लिया. So there are guidelines, there are rules which are meant, and I standing here believe that we all are following it and everybody is following it, including our friends who are sitting in the back row. So there are guidelines. I will not go into the guidelines, but this is one myth that we feel that how does that combination come, but that goes through a series of events, then it comes into the market. So these are a few combinations which have been banned. I'm talking about 2 drug combinations which have been banned, probably some 3 drugs also. I think all of us know that, so I will not go into that because I can hear the beep. We have moved way ahead. So I would say probably if we would have our seniors, I don't see many of my seniors here, all of my colleagues are here. Probably sir is a very senior. Probably when sir was practicing at our age, very early days, I think that time you would agree, sir, that we used to follow that step ladder. We used to start one drug, increase the dose, wait for 3 months, increase the dose. If you reach the target, ठीक है, नहीं हुआ और बढ़ा लिया. But now we have seen that there is something called as glycemic memory. I think that tells us that you have to reach your targets very early. So you have to intensify the treatment, and in that, doing that fixed dose combination helps you in a very larger way. So you have to do aggressive management. Prescription pattern. So I was saying this is, you will be surprised, probably not. You will see 2-drug therapy, 3-drug therapy, monotherapy. So this is the prescription pattern which was done of Indian doctors. So you will see it clearly says that fixed dose combination 2 and yes 3 as well. Minal was again looking at me. 3 bataya nahi to why will I talk? There is 3 definitely. Yes. So I will give you that time. So there are now a number of recommendations also. You will see IDF, RSSDI, ADA, WHO. Now everybody says you start early, hit the target, intensify. If you're not getting controlled with 1 drug, make it 2 drugs. Still not getting controlled, add a basal insulin or some 3 drugs, whatever now we learn from my learned colleague. So the fixed dose combination, what we have now with metformin, you can see we have the sulfonylureas, we have DPP4s, SGL2s, we have glitazones. Of course, Rossi is not there. We just have the PIO. We have the AGIs. The non-metformin combinations also are there. So when you're talking about fixed dose, it is not just with metformin, it is DPP4 with SGL2 as well. This is a very interesting study. You will see it says the efficacy of dual fixed dose combination. So when you give a monotherapy, we know it reaches a amount of A1C. This was a START study where you will see the combination of metformin with glimepiride versus metformin with CETA was studied for a period of 3 months. Glimepiride and metformin combination achieved a better control. So there it said that it had a better A1C control when you give this combination over the other. So when we are talking about the combinations, it is also important that what combination for what patient do you start. And then this is, I think if this slide, if you just concentrate, the study, the MAMSA study, which was a retrospective analysis, it said that DPP4 with metformin needed earlier treatment intensification compared to metformin with either sulfonylureas or thiazolidines. So even in fixed dose combinations, you have to decide what is good for your patient and what amount of time will you be able to keep the sugars under control. So there is a senior panel which has been formed for the fixed dose combination. So what were the recommendations? You will see it said that again rationality of fixed dose combination should be based on what your patient needs. So it depends. If you have somebody, as Sir was saying, it has to be a holistic approach. If somebody with diabetes, with CVD, or diabetes with pre-existing renal disease, then probably after metformin addition of SGL2 or somebody with established CVD, GLP-1 would be the drug of choice. So you have to do it what your patient needs. Fixed dose combination has its own advantage. It helps you to control the sugars early, gives you a good adherence, brings down the cost as well. And dual, I think, we start with monotherapy, we go with dual, and then when it is not getting controlled, then we go for the third therapy. This is a simple ABCD approach. So this is very, very simple. If you will see, how do you do that when you are selecting a patient? You see the age of the patient. So if you are having a younger diabetic patient, you have to be more aggressive, control it faster. If the age is elderly diabetic patient, you do not want to put them for hypoglycemia. Look at the body weight. So when you're giving a combination, if you have somebody with obesity, probably metformin with SGL2 would be the drug of choice. Duration and complications. I can see the watch. I'm done. Yeah, so I'm done. So this is, I would just end it here, and I would say that yes, probably some of the slides we both were sharing, so I have spoken, she will directly go to the third drug. what is the advantage or disadvantage of using a triple therapy. I think we'll do it after when she finishes.